Our courtroom is called to order. So, folks, this is like the grand finale of our day here to see how this actually happens. We have two purposes here. One is to not only show you how an actual trial works, obviously shortened, but then also to teach some of the medicine too, and really most importantly to think about when we do our next shift, some of those things that maybe later we would think, oh man, I wish I'd have put that on my chart, that documentation. Maybe it's just a line, maybe it's 2 lines, but maybe we'll see when we look at this case what that could have been. So hopefully this will actually change care, most importantly to improve patient safety, obviously. I'm going to tell you about this case, and I'm going to first start with the patient's story. And this is a real case. This is an actual person. Her name is Stacy. Names have been changed to protect the innocent. It's a Texas case. And the documentation you see on here is the actual documentation. Nothing has been changed. It's obviously been shortened just a little bit, but the actual important parts of the documentation are all there. Now, here's the deal with Stacy. She was like the greatest of all people. She had a daughter. She had a boyfriend who cheated on her and got pregnant. Who got his, the girl that he was with pregnant, and she like adopted this kid, so she now has 2 kids. I mean, she's like literally as great as anyone thinks they are. Stacy was even better as a person, and Stacy then started developing some symptoms, and at the age of 41, she decided to go to the emergency department. You saw that little appetizer we put on there. And this is the case, chest pain. This is actually documented in triage, pain from above the waist to the head, neck, and arms. Her vital signs are okay-ish. Her blood pressure is a little bit elevated, as is very common with a lot of our emergency department patients. And you can see she has a history of hypertension, says she's had a stroke. It's just a little bit weird as a young person. And it's not documented in the medical part, but in the medications, she's obviously taking medications for diabetes. But the most important part of the chart almost always comes down to the history of present illness and then the MDM. 41-year-old woman, chief complaint of chest pain last day or so, tightness across the chest and upper arms, worse than when she takes a deep breath. So already we're thinking, and we talked about this when I gave that talk about what the patient's presentation is asking us for chest pain, is this ACS-PE dissection, even though the patient is probably coming in because they're concerned about a heart attack, right? So across the upper chest and arms, maybe ACS, maybe dissection, right? Worse than deep breaths, pleuritic, thinking about PE was talked about later. Radiates to the left arm. Interestingly, radiating to both arms is more specific for ACS. That's pretty much the extent of the history of present illness. Now, it's great to put everything else in there, past medical history, et cetera, but the history of present illness is really cursory. We don't find anything about exertion, and there's a lot of other things that we're not really in here. On the other hand, when you think of it now, knowing something bad has happened, it's pretty easy with that retrospectoscope to think, wow, this could have been so much better. And I remember a case that I had, this is like at the end of a night shift, and this patient was a young person, came with some respiratory patients and some chest pain also. And I'm like sitting there and I'm doing all these lectures all over, whatever, all this business, and I'm thinking, I'm so tired. I'm like, there is literally not one single question I think I could ask this patient that would be helpful because she just has a cold. So like thinking about it in this sort of way, and I get it, this patient has some risk factors. So at any rate, completing that history of high blood pressure, diabetes, no nausea, coughing up blood, no syncope, feeling of doom, shortness of breath, sweating, palpitations. Review the nurses note she's a smoker, and there's some past history there's no past history of cardiac disease. Or it does say she has some, sorry. So at any rate, physical exam, she gets a finger stick blood sugar, a chest x-ray is normal. She has 2 EKGs, and they're on the back here. I don't really see anything super exciting. I'm not really sure that I would have necessarily called that a septal infarct. Maybe, maybe not, but whatever. But it certainly didn't show any acute ischemic ST or T-wave type changes that we see on there. Interesting, the medical decision making that we talked about, one thing sometimes you could put in here that would change everything. Well, how about that consideration? Why was, as I talked about earlier, why was this story that we're telling, why was this argument that we're making with our documentation reasonable? So what we did was reasonable and what we didn't do was unnecessary, right? But all they say is chest x-ray and EKGs reviewed. I'm going to be a little bit snarky here. Good job reviewing the tests you ordered. Nicely done, doctor, right? Okay, That's me being a little mean-spirited. I'll stop that now. Albuterol aerosol captopril. It's not really an MDM at all. The medical decision-making note is really the most important part. It's our argument for, again, why we think what we did was reasonable. So at any rate, they repeated the vital signs, and we talked about this earlier. Her complaint was chest pain. Her question was, am I having a heart attack? The question to us is this ACSPE dissection or the other life-threatening cause of chest pain? The diagnoses were both true, hypertension and bronchospasm, but they didn't really address the question that her presentation asked. And then the discharge was a little bit sort of nebulous. It wasn't what we'd like to think of as being action and time specific. So, all that being said, we are going to get our courtroom in order here. We can see our voluntold defendant, Dr. Love, and then this is our defense attorney. Zach, thank you again so much for coming, and defense expert witness, Steve, and John is our plaintiff attorney. These guys actually are actual attorneys. So we're really super honored to have them here, and then Colin is going to be the expert for the plaintiff. So we're going to call this courtroom into order, and I'm going to give the instructions to our jury, which is here. At the very end, we're going to have everybody vote as to what they would come up with while our jury is sort of deliberating, and then we'll see what they decided. I'm going to try to make this a little bit brief, and we'll get to what we want to talk about here. Before we hear the opening statements, and this is instructions that came from an actual medical malpractice case. Short. Before we hear the opening statements of counsel and begin to take the evidence, it's helpful to have some preliminary instructions. After you've heard all the evidence, I'm going to give you further instructions covering additional issues of law. First of all, it's your exclusive duty, the jury, to decide all questions of fact submitted to you in connection with this duty. You must determine the effect and value of the evidence. You must not be influenced in your decision by sympathy, prejudice, or passion towards any party, witnesses, or attorney in this case. The attorneys will have active roles in this trial. They will make opening statements, question witnesses, make objections. And finally, they will argue the case as the last step before you hear my final instructions and commence with deliberations. Remember that attorneys are not witnesses. Since it's your duty to decide the case solely on the evidence which you hear in the case, you must not consider as evidence any statement of an attorney made during the trial, with the exception being if they agree to the facts of the case. Now, this is me talking. This is a really important part. The burden of proof is upon the plaintiff to prove the facts necessary to his case by preponderance of the evidence. Preponderance is the, quote, the greater weight of the evidence. That is the evidence that you believe because it outweighs or overbalances in your minds the evidence is opposed to it. As jurors, you will have the sole and exclusive duty to decide the credibility of witnesses who will testify in the case. As you are all aware, two persons or witnesses might see or hear things differently. So with all that being said, the way that trials typically go, we have opening statements. We're going to have then direct and cross of our experts, direct and cross of our defendant, volunteer defendant physician, Dr. Love, and then there'll be closing statements. So with all of that, are you ready, plaintiff attorney, to proceed with your, plaintiff attorney decide to proceed with your opening statements? And I will tell you guys, I run a very strict courtroom. If you are over time, I will smack with the gavel.
Understood, Your Honor. Can I stand up?
Yes, please.
Can you all hear me? All right. Ladies and gentlemen of the jury, treat chest pain as a heart attack until you rule it out. Not until it seems less likely, not until you feel reassured, but until it is affirmatively ruled out through a proper cardiac workup. This is the fundamental emergency medicine rule that you will hear about today, and it was the failure to follow this rule that led us here. So what happened? During the evening of October 2nd, Stacy came into the emergency room with chest pain throughout her chest and into her arms, and it radiated down through her left arm. It was worsened with deep breaths, and the pain had been present for more than a day. Stacy was in the ER for about 2 hours before she was diagnosed with a bronchospasm and discharged. She was not worked up for cardiac causes, and she died of a heart attack the following morning. Chest pain is a very common symptom in the ER and can be anything from simple indigestion to a heart attack. Because chest pain can be fatal, ER physicians must assume chest pain is cardiac in nature until the evidence proves it is not. To evaluate, physicians are trained to create a differential diagnosis, or a list of possible causes ordered by probability for a physician to systematically work through to identify what is going on with the patient. In Stacy's case, you will learn that no differential was ever created, or at least it wasn't documented in the chart. There is nothing to indicate that Dr. Love was even considering heart attack for this patient, or that any part of his medical decision-making process included cardiac causes. What is documented in the records is just a single line: chest x-ray and ECGs reviewed, albuterol aerosol, captopril, 25 milligrams PO by mouth. His note doesn't explain why these tests and medications were ordered, nor does it explain how they mattered to his evaluation. Based on the limited evaluation, he diagnosed Stacy with a bronchospasm and sent her home. What is interesting is of all the possible things that could explain this patient's chest pain, heart attack, PE, aortic dissection, etc., you will hear that bronchospasm might have been at the very bottom of that list. She didn't have any signs of respiratory distress. Her oxygen saturations were normal, and she didn't have a history of asthma or COPD. Bronchospasm simply did not fit this patient's risk profile. So let's talk about Stacy's risk profile. Her symptoms were consistent with heart attack. She had tightness across her chest into her upper arms, radiating down her left arm. She was noted to be very uncomfortable and complained of 8 out of 10 pain. You will learn that these are not subtle findings. This is a classic presentation of potential heart attack and ischemia that warranted a full cardiac workup on its own accord. On top of that, she had at least 4 major risk factors of cardiovascular disease. She was a smoker, had diabetes, hypertension, and a history of stroke. She was also over the age of 40 and had a family history of cardiac disease over the age of 55. She recently stopped taking her medications as well, meaning her high blood pressure and diabetes were less likely to be controlled. Given everything that was going on, you will hear that it is beyond dispute that Stacy was a high-risk chest pain patient, and her chest pain needed to be treated as a heart attack until it was ruled out. So what should have happened? Well, during today's trial, you'll have the opportunity to hear from Plaintiff's emergency medicine expert, Dr. Colin Kaide. He will tell you that as part of his practice, he teaches every emergency medicine resident that chest pain must be treated as cardiac until it is ruled out. He also makes it a point to stress that while electrocardiograms or ECGs are a useful tool in evaluating a patient with chest pain, a normal ECG is not enough to rule out heart attack due to their limited sensitivity. A proper cardiac workup requires doing serial ECGs and troponin testing over an observation period so you can evaluate for trends and make sure nothing is being missed. Dr. Kaide will tell you this is a classic case of tunnel vision, where Dr. Love was so focused on one potential cause that he failed to consider other possible explanations for this patient's chest pain. As a result, he overlooked the multiple red flags, failed to appropriately assess Stacy's risk profile, didn't order the necessary test to rule out heart attack, and discharged a high-risk chest pain patient who unfortunately suffered a fatal heart attack the following morning. In other words, you will learn that Stacy's death was preventable, and she should still be here today. At the end of this trial, after you've heard all the evidence, I trust that you will agree that a verdict in favor of Stacy and her family is the only just result. Thank you.
All right, thank you, Mr. Markus. Mr. Hoover, are you ready to proceed with your opening statements for the defense?
Yes, Your Honor. Can everybody hear me okay? My name is Zach, and I have the privilege of representing Dr. Love in this case. As the jury, you will hear all the evidence presented in this case, and I want you to reserve any decision until after you have heard all of that evidence. You will hear plaintiff present their case first, and then we as the defense will have our opportunity to let you hear from Dr. Love. Now, you will be instructed in this case that you are to consider all of the facts and evidence and to consider Dr. Love's care according to the standard of care. And that legal definition of standard of care is what a reasonable emergency medicine physician would do in the same or similar circumstances. Now, this standard is prospective, knowing what Dr. Love knew in the ER when Stacy presented on October 2nd, 2007. Dr. Love did not have the benefit of hindsight of knowing that this patient would die the next day, and you are not to judge him based upon the outcome solely because this patient died. Now, you will hear testimony from Dr. Love about his examination and assessment of this patient, and you will also hear testimony from a board-certified emergency medicine physician, Dr. Wipprecht. And both of these physicians will tell you that Dr. Love's care and treatment complied with the standard of care, was reasonable under the circumstances based upon what the patient's presentation was. And the evidence will show that all the data gathered by Dr. Love led him away from a cardiac origin of this patient's presentation. The patient had many negative findings that are commonly associated with an acute coronary syndrome. The patient did not have any nausea, did not have any vomiting, did not have any diaphoresis, no feeling of doom, no shortness of breath, no palpitations. But there were positive findings that led Dr. Love to a pulmonary origin of the patient's presentation. She had wheezing. She had splinting on exam and decreased air movement. She also had a history of smoking. Now, the patient did report chest pain, but it was pleuritic chest pain. It's an atypical presentation for what plaintiffs are going to try to argue in this case. And you will hear the testimony from the doctors in this case that not all chest pain is fatal. Chest pain can have non-cardiac origins. You can have chest pain related to pulmonary and respiratory causes. The evidence will show that is what Dr. Love reasonably believed Stacy had in the ER. Now, you will also hear evidence about Dr. Love's physical examination of this patient. He did a complete cardiovascular physical exam, listening to the patient's heart. This was all normal. Regular rate, regular rhythm, no murmur, no gallops, no rubs, full and equal pulses. You will hear testimony from the doctors that this is inconsistent with an acute coronary syndrome at this time. The patient also had other negative findings of heart failure. There was no pulmonary edema, no cyanosis. All of this information in the broad picture of this patient's presentation led Dr. Love to his reasonable diagnosis. Now, Dr. Love did not stop there, as the evidence will show. He ordered tests. He ordered EKGs, and you will hear that EKGs are a very useful tool in ruling out and diagnosing cardiac conditions. Dr. Love not only ordered one EKG, but he ordered two EKGs, an hour and a half apart from one another. All the doctors will tell you that these EKGs are normal. There is no acute cardiac ischemia or injury identified on these EKGs. Dr. Love also ordered a chest x-ray that could rule out life-threatening causes of chest pain, like an aortic dissection. And you will hear that that was not indicated or evidenced on the chest x-ray. Now, also during the ER, the patient received some albuterol treatment for the lungs, a respiratory cause of the patient's presentation. The patient improved over the 2.5 hours in the ER. Vital signs improved, pain improved. The patient was hemodynamically stable at the time of discharge, and it was reasonable and appropriate for this patient to go home with a follow-up with their primary care doctor. So, ladies and gentlemen, after you hear all of this evidence, plaintiff has the burden of proof to prove that Dr. Love's treatment was not reasonable. And after you hear all the evidence, it is the defense's position that you will conclude that Dr. Love's care and treatment was reasonable in this case. Thank you.
Thank you, Mr. Hoover. So now we proceed with the direct and cross-examination of our plaintiff expert. Then it'll be our defense expert, and then it'll be our physician defendant.
Good afternoon, doctor.
Good afternoon.
Can you please state your name and position for the jury?
My name is Colin Kaide. I am a professor of emergency medicine at The Ohio State University Wexner Medical Center.
And Dr. Kaide, are you licensed and board certified in emergency medicine?
I am.
And do you spend at least half of your time in the active clinical practice of medicine?
I spend about 80% taking care of patients.
Doctor, in your role as an emergency medicine physician, do you see patients with chest pain?
All the time.
Okay. And in your role as an emergency medicine physician, do you train residents?
I do.
And do you train residents about seeing patients with chest pain?
I do.
Doctor, tell me, how common is chest pain in the emergency department?
Well, it makes up maybe about 5 to 10% of the patients that we see.
And why is chest pain such a critical symptom to evaluate correctly?
Because many times it's nothing, but the times when it is something, it can oftentimes be lethal, and it can represent some very serious, very dangerous disease processes that if we miss, the patient can die.
Is there any foundational safety rule that you use when treating patients with chest pain or that you impart upon your residents when you're teaching them?
I do. I tell them that chest pain is of cardiac origin or is something serious until you can prove otherwise.
Okay. And is that something that you believe is required by the standard of care?
It is absolutely required.
Okay. And why does the standard of care require treating chest pain as cardiac until it is ruled out?
Because it's something that can lead to severe disability or death in a patient, and that is high enough risk that I have to be very careful that I'm making sure I do the right thing for my patient.
Okay. And what are some of the things that you can do to rule out cardiac causes of chest pain?
I can do serial EKGs, I can do troponins, and I can do a single troponin. In some cases, I can do multiple troponins. And if my patient is high enough or in a high enough risk situation, I can risk stratify them and then maybe get them a stress test or a coronary CT, or admit them to the hospital and get a cardiologist to do a catheterization of my patient.
Okay, so we've listed off a number of things that can be done. Are there certain things that are required to be done by the standard of care?
Serial EKGs and the ordering of a troponin are required in order to be able to rule out the diagnosis of cardiac ischemia.
And that's for every single patient that presents with chest pain in the ER.
If I give it serious enough consideration that I think it's really a cardiac cause, or even something close to a cardiac cause, I have to do those things, absolutely.
Okay, doctor, let's switch gears a little bit and talk about the concept of a differential diagnosis. Can you tell the jury what that is?
A differential diagnosis is a list of possible things that could be causing my patient's problem, and they're generally ordered in the order of probability, with the most common thing being the first thing in my differential diagnosis, all the way down to other things that I need to consider in my particular patient.
And why are differential diagnoses important?
It's very important so that I don't miss anything important when I'm taking care of my patient.
Okay. I've heard of this concept of ruling out the worst first. Is that something that exists when working through a differential diagnosis?
Yes, I have to consider the things that are most likely to harm my patient, and I have to rule those things out before I can move to things that are of lesser value in taking care of that patient. I have to be able to prove that they're safe when I want to discharge them.
Okay. I'd like to draw your attention to Stacy's care and treatment in this particular case. What would be on her differential diagnosis?
On her differential diagnosis, first and foremost, when she described chest pain, I have to think about cardiac ischemia. I also have to think about PE because of the nature of how that pain was described. Although I think it's less likely, I have to consider a dissection of the aorta. Once I've ruled out those things, I can consider things that are less likely, like maybe GERD or something more benign, gallbladder disease, pancreatitis, possible pneumothorax. But before I can move down the list, I have to prove it's not something that's going to seriously harm or kill my patient.
Okay. Doctor, I also want to talk about the idea of risk stratifying a patient. What are some of the major risk factors for cardiovascular disease?
Some of the major risk factors can include diabetes, especially in patients who have poorly controlled diabetes for a long time, hypertension that goes uncontrolled or poorly controlled, a history of cardiovascular disease, a history of stroke, a family history of somebody, a first-degree relative who has a serious heart issue, the fact that somebody could be smoking for any extended period of time. Those are very serious risk factors that can contribute to a patient's disease to be thought of as cardiovascular in origin.
Is it fair to say that Stacy had multiple risk factors of cardiovascular disease in this case?
She absolutely did.
Okay. Do you know how many she had?
I was able to count smoking, hypertension, diabetes, and based on her history that she had a stroke, CVA, and previous cardiovascular disease. I can also say that her father had some sort of cardiovascular disease, so that comes down to about 5 right now.
Okay. And why is it important when assessing patients that they have more than one of these cardiovascular disease risks?
Because these things are not just additive, but they multiply together. And the more things that you have, the more likely it is that the person will have a disease that you have to rule out. And having those risk factors doesn't prove they have heart disease, but it puts you in a pathway that you have to go the next step and do the kind of workup to make absolutely certain that those are not things that are causing your patient's problem.
Okay. Doctor, on October 2nd, what was Stacy's chief complaint in the emergency room?
It was chest pain. And it was chest pain that went, according to what the chart said, it was everywhere above her waist all the way up to the top of her body. And that it was chest pain that went to both sides of her body and down her arm on the left side.
Okay. And in terms of we've already talked about what you would put on her differential diagnosis, but in terms of her presenting symptoms, how would you classify that?
I would classify those as high-risk symptoms for cardiovascular disease.
Okay. And this chest pain that radiates to both arms and down the left arm, what does that suggest to you?
That suggests that this person has cardiac origin of her chest pain until proven otherwise. And I have to take that as the highest risk symptom, or the highest risk thing that I think that this patient has. And I have to prove it's not a heart problem before I can move on.
Okay. You reviewed Dr. Love's care in this case.
I did.
What efforts did he make to rule out cardiac origin of this chest pain?
Well, he took a history, albeit an incomplete history, but he took a history, and he did an EKG, and he was thoughtful enough to get a second EKG on this patient, but that's about where the workup stopped.
Okay. Was that sufficient?
That was not sufficient to rule out cardiac disease.
What else did he need to do?
He needed to strongly consider this, and he needed to get a troponin, and if that troponin was negative, he needed to get a second troponin because of the nature of the way this patient's chest pain presented. He needed to prove that she did not have a pattern that was consistent with a heart attack.
Explain that a little bit more. He needed to get a second troponin because of the nature of how this presented. What does that mean?
That means that the first troponin could have been normal or slightly elevated, and if the pattern of that troponin is for that troponin to be increasing over time, that is a very strong indicator that this patient's chest pain is cardiovascular in origin. And based on the way she described this, I would be happy with a single troponin because she said that this chest pain was going on for an entire day, so I'd be happy with a single troponin even in this patient.
Okay. Dr. Kaide, we saw that Dr. Love's ultimate diagnosis of this patient was a bronchospasm. I take it you disagree with that diagnosis?
I very much do.
Why?
Well, I'm going to say 2 words to answer that question, and those words are non sequitur. That means it does not follow. It does not follow logically, because he came to the conclusion that her problem was related to a respiratory cause simply because she was wheezing, but he took no time to be able to rule out the more serious problem in light of all of her risk factors and the type of pain she was having. As far as I know, that kind of problem doesn't cause chest pain that radiates to both arms and then goes down one of your arms and makes you feel that unwell that you have to come to the ER.
Okay. Well, Dr. Kaide, I want to be fair to Dr. Love. The patient did have wheezing, correct?
That is correct.
And I assume you don't believe it's inappropriate to have provided the albuterol aerosol treatment. Fair?
That is fair.
Okay. Was it possible for Dr. Love to work up 2 potential diagnoses at the same time?
He absolutely could have worked up 2 diagnoses at the same time. One does not exclude the other one.
And despite the fact that he appeared to focus his attention on the possible bronchospasm based on this patient's wheezing, is it your opinion that he also needed to continue working up this patient for potential cardiac causes?
He cannot have stopped simply because he thought that this was bronchospasm, especially in light of the way this patient presented. He needed to fully work up that other chest complaint because that chest pain, calling this bronchospasm alone is not enough to be able to exclude a more serious diagnosis. That was staring him in the face when this patient presented.
And doctor, I just want to make sure that the ladies and gentlemen of the jury are clear. Is it your opinion that Dr. Love needed to order serial troponins for this patient?
Absolutely.
Doctor, what likely would have happened if Dr. Love did order the serial troponins for this patient?
He would have found a positive troponin that would have led to a further workup of this patient. They would have gotten cardiology involved, and this patient would have gone to the cath lab in a timely fashion prior to her having a cardiovascular collapse at home by herself and then dying.
And doctor, do you believe that Stacy's death was directly caused by the failure to treat her chest pain as cardiac until proven otherwise?
Absolutely.
I have no further questions.
Thank you. Mr. Hoover, if you want to proceed with your cross of our plaintiff expert.
Thank you, Your Honor. Dr. Kaide, in all fairness, the respiratory exam that Dr. Love performed on this patient had more positive findings than just wheezing, correct?
That's what he said in the chart.
Okay, it's also included decreased air movement, correct?
I'm not sure he could necessarily tell me that this patient had lower air movement, but that's what he documented.
Okay, and he also documented there was prolonged splinting in his respiratory exam, correct?
That's not something I would typically describe, but yes, he said that in his exam.
Okay, and the patient also had a history of smoking, correct?
That's correct.
All right. And doctor, patients can have bad outcomes even when doctors comply with the standard of care, correct?
That is true.
And not all patients that present to the emergency room with chest pain have an acute MI or an acute cardiac condition, correct?
That's correct. That's why we have to spend the time to sort them out.
And not all patients who present to the emergency room with chest pain are required to be admitted to the hospital, correct?
After I've decided it's not something serious, some of them can be sent home, absolutely.
Okay. And chest pain can have a wide differential of etiologies, correct?
Yes, it can.
Okay. And those can be non-cardiac in origin, correct?
They can.
It can include pulmonary causes of chest pain, correct?
That is correct.
It can be gastrointestinal causes of chest pain, correct?
That is also true.
It can be musculoskeletal causes of chest pain, correct?
Yes.
And there can even be psychiatric disorders that could cause chest pain, correct?
Unfortunately, yes.
And there are typical or classic symptoms associated with an acute cardiac syndrome, correct?
That's true, although patients don't read textbooks.
Okay. And pleuritic chest pain is not one of those classic symptoms of presentation of acute cardiac syndrome, correct?
That is correct.
Okay. And in Stacy's case, I think you described her chest pain. I just want to make sure I get this right. That you said she had chest pain everywhere, in the upper, from the abdomen up to the arms, extremities, the head, correct?
That's what's noted in the chart, correct.
Okay. Is it correct to call that diffuse myalgias?
I wouldn't characterize it as diffuse myalgias, especially in the context of how she said it.
Well, you didn't hear what she said. You weren't there. Fair?
That's correct.
Okay. And it was not focal. It was not reported as focal pain, correct?
Correct.
All right. And shortness of breath and diaphoresis can be classic symptoms of acute coronary syndrome, correct?
They can be.
Okay. And those were absent in this case, correct?
That is correct.
All right. And I want to talk about some things that we can agree on. Dr. Love ordering 2 EKGs complied with the standard of care. Those 2 tests, correct?
Those 2 individual things, yes, they did comply with the standard of care.
Okay. And the chest x-ray ordered by Dr. Love, that was also a reasonable test to order in this presentation, correct?
Yes, it was.
All right. And the EKG gives information about any cardiac ischemia that may be present, correct?
That's correct.
All right. And those EKGs, both of them, ordered by Dr. Love, were normal, correct?
They were normal, that's correct.
In other words, that means there was no evidence of acute ischemia of the heart on these EKGs, correct?
That's correct, but I would like to have seen him say something in there about whether those EKGs correlated to when the patient was having active chest pain or not, but I would agree with the statement you said.
Okay. And there is no aortic dissection seen on the chest x-ray, correct?
With the limited capability of that to be useful, there was no evidence that the x-ray was abnormal. But I can't say there wasn't an aortic dissection based on the chest x-ray alone.
Okay, that's fair. And with the EKGs, if Stacy had an acute MI, there would have been some abnormality seen on those EKGs, correct?
That's not necessarily true.
The troponins that you talked about, the standard of care does not require a troponin to be ordered for every patient who presents to the ER with chest pain, correct?
That's correct.
If there is an alternative cause of chest pain, such as one of the several we went through, a pulmonary source, gastrointestinal source, musculoskeletal source, troponin would not be required by the standard of care, correct?
If there's a plausible alternative diagnosis, yes.
And patients who are in the ER who have acute cardiac syndrome, that is not going to respond with treatment of albuterol, correct?
That would be my first choice of treatment, correct?
Albuterol, you don't typically prescribe albuterol for somebody with an acute cardiac condition, right?
That's correct.
All right. And so Stacy's improvement in the ER with her vitals and her pain, improving over the 2 hours she's there in response to albuterol treatment, could lead a emergency room doctor to a pulmonary source of the presentation, correct?
It could, but true, and unrelated is also important here. She could have gotten better from some wheezing, but that doesn't mean she didn't have cardiac disease. So I'll only agree to your statement to the extent that it showed that one thing got better, but it didn't prove the other thing.
Okay. And doctor, will you agree that two different physicians can have different opinions on the diagnosis and treatment of a patient, but both of those doctors both be reasonable?
Yes.
All right. No more questions. Thank you.
Okay, so now we'll proceed with our direct and then cross of our defense expert, and we'll keep that to 5 minutes per person for the presentation, and we'll have a little bit more time with our defendants. Thank you.
Dr. Wipprecht.
Hello.
Can you please introduce yourself to the jury?
Hi, everyone. My name is Stephen Wipprecht. I'm an emergency physician at Ohio State University, formerly an emergency physician at Indiana University, and one of the core faculty at Ohio State.
And what is your specialty practice, Dr. Wipprecht?
So I'm an emergency physician, so my specialty is in emergency medicine, and specifically within emergency medicine education of both new and practicing physicians within our field.
And are you board certified?
Absolutely.
And what board certifies you?
The American Board of Emergency Medicine, called ABEM.
And do you spend greater than 50% of your time in either the active clinical practice or active teaching of medicine?
Absolutely. I try to spend almost 100% of the clinical hours for clinical faculty at my place, as well as teaching on top of that.
And in your experience as an emergency room physician, have you diagnosed patients with acute cardiac conditions?
Absolutely, almost every single day.
And have you, in your experience, have you also diagnosed patients with respiratory conditions such as bronchospasm?
Absolutely, sometimes even more commonly.
So, doctor, are you familiar with the standard of care that applies to Dr. Love's care and treatment of Stacy, in this case, in the emergency room?
Yes, sir, I teach it every day, too.
Okay, thank you. All of the opinions that you're going to offer today, can we agree that those are going to be offered to a reasonable degree of medical certainty?
Absolutely.
Okay. And have you reviewed the Stacy's medical records in this case of the ER visit in 2007?
I have, yes, sir.
And do you have opinions on the reasonableness of Dr. Love's care in this case?
Absolutely happy to share it, yeah.
Yes, and please, just generally, what are those opinions?
So my opinion is that an unfortunate thing certainly happened in the future, but if we concentrate only of what happens in the future, we're not truly considering what happens in the moment when we evaluate patients. In the moment when this patient was evaluated, the patient came in with what we would consider very nebulous concerns, where her pain was in so many areas of her body that truly considerations could be of so many things. And Dr. Love certainly considered all of those things in his care, and he proved that and showed that with the workup that he received and got, within a very reasonable manner in this case. The patient seemed to get quite a bit better with the treatments that he focused on, and the workup that he got was very reassuring. And so my opinion is that this was a very reasonable workup and treatment of a patient who got better, felt well, and felt comfortable going home under his care.
Were the EKGs ordered by Dr. Love appropriate?
Absolutely. Yes, sir.
And what is the significance of those EKGs in this case?
Yeah, an EKG is our first-line diagnostic tool to consider somebody of having an acute coronary syndrome or other cardiac condition, which might both risk stratify them into a high or low risk group, as well as consider how our treatments might be impacted in this individual patient.
And what are your interpretations of the two EKGs in this case?
Yeah, so I looked over these quite considerably, even for the most subtlety of findings, even now knowing what happened with the patient, and they both were 100% and completely normal, even despite what the computer misrepresented in the initial EKG.
And in this patient, with those two EKGs, how does that influence a cardiac origin of the patient's presentation?
Yeah, I think in a patient that presents in a very nebulous or kind of non-structured way, where their pain is all over, you're considering potentially how do I localize this patient's pain. Certainly normal EKGs, as well as a normal physical exam and the like, certainly point you away from a cardiac etiology.
Is it fair to say that those EKGs would reduce the likelihood of an acute cardiac condition in this patient?
Absolutely, that's scientifically true.
And what is the significance of the patient's wheezing and respiratory complaints?
Yeah, and a patient who is around 40 years of age who has smoked even more than a few years, the diagnosis or the consideration of new wheezing in the setting of very diffuse pain all over the body certainly points you towards a pulmonary etiology of both the foci of the symptoms that are causing today, as well as the underlying cause of why the patient came in that day.
Okay. And taking all of those factors into consideration, was it reasonable for Dr. Love to diagnose the patient with a bronchospasm?
Yeah, I would absolutely call this patient bronchospastic or reactive airway disease. She absolutely had that, and it was shown with the treatments to get better, which is the definition of reactive airways.
And if Dr. Love came up with that diagnosis, did that require him to also order a troponin?
Absolutely not. The pulmonary and the cardiac system are certainly separate.
All right. Thank you, doctor.
Good afternoon, Jack. Good afternoon, doctor. Can you hear me?
Hi, sir. Yes, I can. Thank you so much
You
for
guys
having
hear me talking?
Hold it real close to you. Yeah.
Hello?
Are they different?
Is that better? Yes, I can hear it too.
Hi, sir. Nice to meet you.
Good afternoon, doctor. On direct examination, you described this patient's concerns as nebulous and being all over her body. You reviewed the medical records in this case, fair?
Sir. Yes, sir.
And the medical records in this case very clearly indicated that this was a chief complaint of chest pain from above the waist to the head, neck, and arms. Is that what you are using to categorize this as nebulous pain all over her body?
So I think you're referring to the nursing documentation, which said she had waist pain all the way through her body, up through both arms and into her head. That certainly is one of the things I considered when we were talking about that all-over pain.
Okay.
Yeah.
What else are you considering?
Yeah, so of course the physical exam, the history and physical are key in the consideration of the underlying cause. And so both the physician as well as the nursing documentations the chief complaint that stated the pain was all over without focality, which is that specific area of pain that's the primary cause.
Okay. Doctor, do you have the medical records in front of you?
Yes, sir.
Okay. I'd like you to show me where in the records the nursing notes talk about pain being all over her body.
Yeah, yes, sir. So it says pain from above the waist to the head, neck, and then both arms in the nursing chief complaint that they wrote down. Yes, sir.
So we're talking about the same note itself that says chest pain, pain from above the waist to head, neck, and arms. And that is the note that you were relying on in saying that her pain is nebulous and all over her body. Fair?
Yes, sir. We were looking at the notes that they wrote.
Okay.
Yes, sir.
Nothing else, just that singular note.
I wasn't there, so we have to obviously rely on the documentation.
Okay. And we can agree that the documentation in this particular case is left to be desired. Fair?
Certainly, the documentation is just a reflection of a small proportion of what happened on this visit. Yes, sir.
Okay. And I assume you also reviewed the HPI?
Yes, sir.
The HPI, is that something that would have been written by the nurses or Dr. Love?
So the history of present illness is a reflection of even a subset of the presentation and was written, I assume, by Dr. Love. Yes, sir.
Okay. And that HPI goes on to further specify the complaints of this patient. 41-year-old woman with chief complaint of chest pain of the last 1 day or so. Pain is a tightness across the chest and upper arms, which is worsened by deep breaths, radiates to the left arm. I read that correctly, correct?
Yes, sir. That's what's written there.
And hearing that further tailored complaint of the pain being tightness across the chest, into the upper arms, and radiating down the left arm, is it still your opinion that this patient's complaints were nebulous?
Yes, sir. I think that's a reflection of one part of the patient's complaint. Certainly, we often will write down one of the things that we are concerned about. I think that's an accurate reflection for Dr. Love of his consideration of this initial patient's presentation. Yes, sir.
Okay. Doctor, would you agree with me that chest pain radiating down through the left arm is indicative of potential ischemia?
It certainly is one of the considerations, absolutely.
Okay. And a reasonably prudent and careful physician would look to determine whether it is a byproduct of ischemia. Fair?
Yes, sir. I think that is definitely one of the considerations that we certainly look at when we evaluate a patient initially.
And you agree that some of the testing that you can do to look for ischemia is an EKG. You talked about that on direct, correct?
Yes, sir. Yep.
And troponin testing. Fair?
It's testing, especially if we're considering cardiac to be the primary source of this, absolutely.
Okay. Well, we can agree that chest pain radiating to the left arm is indicative of potential ischemia. Fair?
Yeah, if that's how the patient's presenting solely with that complaint, absolutely.
Okay, so now it's solely with that complaint.
Yes, sir.
I just want to make sure that the jury is clear. You are recategorizing, reframing how we're perceiving this patient. Is it your testimony today that an EKG and troponin workup is only appropriate if the patient is only complaining of chest pain radiating down the arm?
Absolutely not, sir. Yeah, so I will get a troponin for many reasons. Some of those include cardiac ischemia, acute ischemia. But what you were saying was chest pain radiating down to the arm certainly is concerning for ischemia, and I would say yes if that was the specific complaint of the patient, why they presented.
Okay. I mean, the specific complaint that the patient complained about was chest pain that went through her chest and up into her arms, right?
Yeah, from her waist all the way through her
seems like a
head.
pretty specific complaint by the patient, fair?
If the patient complains of pain all the way from the abdomen to the head, that is atypical for a chest pain presentation, where I would only consider cardiac chest pain. Yes, sir.
Doctor, are you familiar with the 2022 American College of Cardiology Expert Consensus Decision Pathway on Evaluation and Disposition of Acute Chest Pain in the Emergency Department?
It is certainly one of the guidelines we utilize in our daily practice. Yes, sir. Amongst a myriad of many.
Okay. You're familiar with them?
I would have to look up exactly word for word. I don't have it memorized. Yes, sir.
Okay. Doctor, I'd like to present you with a decision pathway that is published as part of this article. And I will ask you, have you had a chance to review this?
Yes, sir.
And is this a decision pathway that you're familiar with?
Yes, sir. Hospital protocols for chest pain will include certain things that look similar with some differences. Yes, sir.
And is this decision pathway consistent with your understanding of what the standard of care requires in working up patients presenting to the ER with chest pain?
Yeah, it depends on how the patient might present, right? You know, we're talking just specifically chest pain. Obviously, patients don't often come in with one concern or one complaint. Obviously, this patient came in with a myriad of other complaints and concerns too. But if this was specifically what I was working up, this is something that I utilize. Yes, sir.
Okay. Doctor, we can agree that this patient's chest pain that radiates to her left arm is concerning for potential acute coronary syndrome. Fair?
Certainly ACS is on the differential. Yes, sir.
And under this pathway, the first step is to perform a 12-lead EKG, correct?
Yes, sir. Yep.
And that's what Dr. Love did,
He
correct?
did, yes, sir.
He was concerned of cardiac causes, fair?
That was one of his concerns, absolutely.
And he started working her up for cardiac causes and did an EKG, fair?
He did, yes, sir.
Okay. And then from here, this pathway branches into two separate parts. One is if the EKG shows signs of STEMI, you go down that pathway, which, in fairness, this EKG did not show STEMI, fair?
That's
correct?
true, sir, yes.
And then the second pathway is if it's non-ischemic and normal, you keep going down that pathway to apply what is noted as a HS-CTN-based CDP. What does that mean?
So that's the high sensitivity troponin that Dr. Kaide and I have spoken about that you would do for specific ACS considerations if that was the chief or primary concern by the
Okay.
physician.
So this algorithm is requiring that a troponin be done for this patient when you're concerned about cardiac causes of chest pain.
If the patient falls within this algorithm and the physician chooses to utilize this algorithm, that would be a consideration. Yes, sir.
Okay, and you've already testified that this algorithm is consistent with your understanding of the standard of care?
So this algorithm, amongst a myriad of other algorithms, we certainly use when we're concerned for ACS.
Understood. And doctor, is it fair to say that Dr. Love did not perform a troponin for this patient?
Yes, sir. I did not see a troponin within the ordering of.
He did not continue down this pathway
No,
that
I
is
think-
recommended by the American College of Cardiologists?
Yes, so the dynamic change of how the patient presented with the normal EKG certainly sent Dr. Love down a different pathway of treatment that is also very reasonable based on this particular patient. Yes, sir.
That's all the questions I have. Thank you.
Thank you, sir.
All right, thank you. For our expert witnesses, Dr. Love, are you prepared to come to the stand as the defendant physician?
I am.
Okay, so we will start first with Mr. Markus, and we will do direct first. You normally have direct first? Okay, yeah, all right, that sounds great. And so we will give our defense attorney just a few extra minutes to make sure things are a little more fair. But I'd ask you to confine it to 7 or 8 minutes, and then we'll do yours like 5 or 6 or 7.
Dr. Love, can you please introduce yourself to the jury?
I'm Andrew Love. I'm an emergency medicine physician at Ohio State.
All right. And are you experiencing the diagnosis of acute cardiac conditions in patients in the ER?
I am.
Okay, are you also experiencing diagnosing respiratory conditions such as bronchospasm in the ER?
I am.
And are you familiar with the standard of care that applies to an emergency medicine physician in the ER?
I am.
Okay. And can we agree that all the opinions you will offer today are opinions you hold to a reasonable degree of medical probability?
That's correct.
All right. Did you treat Stacy in the emergency room back in October of 2007?
I did treat Stacy.
Okay. And did you perform a physical examination of Stacy in the ER?
I did.
And did you obtain a history of present illness of Stacy in the ER?
I did.
And did you perform the history, the HPI, and the physical exam based upon your education, training, and experience as an emergency medicine physician?
Yes, I did.
And walk me through your HPI of this patient. When she is reporting that she has pain and tightness across her chest with deep breaths, what does that tell you?
So what it tells me is it's less likely to be coronary cause. So if you're having a true ACS crisis, you're less likely to have pleuritic chest pain, especially when you're having more diffuse pain that goes all the way down to your waist as well as up into your head. And she was complaining of headaches as well, which also led me away from ACS.
And there were a lot of negative history reported. She denied nausea, vomiting, coughing blood, syncope, feeling of doom, sweating, palpitations. What does that tell you?
So it tells me also, it leads me away from considering ACS, especially in, again, the case where she's just having diffuse pain.
And did you perform a physical exam and listen to the patient's heart?
I did.
Okay. And what were your findings in that physical exam of the cardiovascular system?
It was a normal cardiac exam. She had normal rate and rhythm, no murmurs, rubs, or gallops. It was a very normal exam.
And if a patient has ACS, do you typically expect to find some abnormalities in a cardiovascular exam?
Sometimes you can if they're in evidence of heart failure from that ACS.
Okay. But regardless, you still ordered an EKG, or 2 EKGs, I'm sorry, correct?
I did.
Okay. And why did you order the 2 EKGs?
To look for dynamic changes between the two that'd be more concerning for an acute coronary syndrome.
Okay. And what were your findings when you reviewed these EKGs?
Both EKGs were normal without any dynamic changes.
And what is the significance of obtaining 2 EKGs rather than just relying on one normal EKG?
It increases your sensitivity looking for those dynamic changes. Had there been dynamic changes, ACS would have been much more likely on my list of differential diagnoses.
Okay. So you heard some testimony and statements from the other side over there about the documentation or lack of documentation, and that you did not perform a cardiac workup. Do you disagree with that?
So I do disagree because I did document that 2 EKGs were obtained, which shows that I was considering ACS on my differential, and both of those EKGs were normals without changes. So therefore, I think the documentation speaks for itself that ACS was considered.
And you also ordered a chest x-ray. Why did you order that test?
So you can look for pneumonia, especially given that she was having the pleuritic pain. You can evaluate for pneumothorax, pneumonia. You can even look at the aortic root, see if there's any dilation in the mediastinum.
And so the chest x-ray being within normal limits, how does that impact your differential and ACS and other causes of the patient's presentation?
It doesn't necessarily change my reasoning for ACS, but it does make infectious processes, pneumothorax, significantly less likely.
And your respiratory exam of the patient, what were the notable findings during that?
So it had significantly diminished air movement bilaterally with significant wheezing as well.
And how does that influence your differential?
So given the pleuritic chest pain with those respiratory findings, it does make me believe that this was primarily a respiratory complaint.
And did you order respiratory treatment for this patient in the ER?
I did.
What treatment did you order?
2 doses of albuterol.
And what was the patient's response to those medication or that treatment?
So not only did her wheezing improve, but also her pain decreased from an 8 to a 3 out of 10.
And what does that tell you as an emergency medicine doctor when a patient's presentation improves with that treatment?
So I have never seen a case of ACS that improved with albuterol only.
And taking all of the data that you gathered and your gestalt of this patient and her presentation, did you need to order a troponin?
No, this was primarily respiratory from my assessment and physical examination of her and her response to treatment, which means that I did not need to go down the cardiac route of ordering troponin.
Thank you, doctor.
Thank you.
Good afternoon, Dr. Love.
Afternoon.
Chest pain must be considered cardiac in origin until ruled out. Do you disagree with that medical principle?
I do not when the chest pain is consistent with anginal symptoms.
Okay. And in this patient, you don't believe her chest pain was consistent with angina symptoms?
I do not, based on the presentation that she told me in her physical exam, I do not believe that this was anginal.
Chest pain that is throughout her chest, into both arms, and radiates down her left arm.
And goes down into her waist and up to her head.
And you believe, doctor, why do you believe that this patient's chest pain went down into her waist?
So there are a variety of causes. Diffuse myalgias.
Hold on, doctor. Why do you believe that? Did she tell you that?
Yes,
Did you document that in your note?
it is documented in the record.
What's documented in the record is pain above the waist. You just testified that it was pain that went down into her waist. As we sit here today, are you telling the jury that you affirmatively remember the patient telling you that the patient's pain went down into her waist?
It is also documented that it did go down into her waist in the medical record.
Into her waist. At your
Down
testimony.
to her waist.
Down to her waist is what your testimony. Doctor, do you have the records in front of you?
I do.
I'm going to ask you to look at the chief complaint that says chest pain, pain from above waist. Pain from above waist.
Correct.
Where is it documented that the pain goes into her waist?
So it does say above waist.
Okay. Doctor, you testified during your direct examination that you've never seen a case of ACS that got better without buterol treatment.
That's correct.
Correct. Are you familiar with the placebo effect?
I am.
Where patients will feel better because they've been given some medication, even though that might not actually be treating that patient's symptoms?
Correct.
Okay. As we sit here today, do you have any opinion as to whether Stacy was feeling better because of the placebo effect in this particular case?
It's certainly possible, but with physical exam findings that showed her improvement along with her symptom control, it led to a respiratory cause.
Okay. Doctor, we can agree that this patient exhibited signs consistent with potential acute coronary syndrome. Fair?
Fair.
And we can agree that you got this patient an electrocardiogram, as would be indicated under the American College of Cardiology's decision pathway. Fair?
Fair.
And you ultimately chose it was not necessary to get this patient a troponin, as would be recommended through that decision pathway. Correct?
So the decision pathway, again, only applies for people where this is an true anginal symptoms. It does not apply for all causes of chest pain and all presentations of chest pain.
Okay. Doctor, let's talk about your diagnosis of bronchospasm. We can agree that this patient had no cough,
Correct.
no shortness of breath,
Correct.
no history of asthma,
Correct.
no history of COPD,
Correct.
and her oxygen
with
saturation was
smoking.
normal.
Correct.
Okay. Nonetheless, you felt it was reasonable that this patient had a bronchospasm.
Based on
Fair.
her wheezing on exam and diminished breath sounds, I think that's accurate.
Okay. And it's your testimony that it was a reasonably careful physician would not believe that this patient's chest pain was anginal in nature, but rather pleuritic.
Correct.
Doctor, would you agree that you are allowed as an emergency room physician to investigate two potential causes at once?
Correct.
And do you believe a reasonably careful and prudent emergency room physician would have also further investigated cardiac origin for this patient's chest pain in addition to what you were doing on the bronchospasm side?
Yes, with the 2 EKGs.
Okay. And, at some point, I don't want to beat a dead horse because your opinion is going to be what it's going to be. But I just want to be clear for the jury, you disagree that the American College of Cardiology decision-making pathway does not apply to this case.
Yes, that's correct.
And troponin testing was not necessary.
That's correct, based on the presentation at the time that I saw her.
Doctor, let me ask you, if troponin testing was done, do you believe it would have been abnormal?
I can't speculate on whether it would be abnormal or not.
Okay. I have no further questions.
Thank you.
Okay, we are ready for our closing statements. We will have 5 minutes each. We will use a timer, and there will be a bell rings when the 5 minutes is up. First is our plaintiff, and then defense is next. Please proceed.
Ladies and gentlemen, all day you heard about one simple safety rule. A rule so foundational that every single emergency medicine resident knows it. You treat chest pain as cardiac until it is ruled out. This case is all about whether the cardiac causes were actually ruled out. You just heard Dr. Love testify that he felt the cardiac causes were ruled out because there were two normal EKGs. he also felt that the patient's chest pain was not anginal in nature because in his perception, it was diffuse pain all throughout her body, going all the way into her hips, despite the fact that at no point is it documented in the medical records that this patient had pain in her hips. The pain was very clearly focused on the chest. It went into the arms and went down her left arm. That is a classic presentation of ischemia. And a reasonably prudent physician, which is what the standard of care requires in Ohio, would have done a further cardiac workup. One of the other things we've talked about today is a differential diagnosis. You have to rule out the worst first. What Dr. Love did was he ruled out a potential cause. She may have had a bronchospasm. She may have also had a heart attack. And I think it's very likely that she was having a heart attack based on what happened the next morning. You heard Dr. Kaide say that. You can treat two things at once. It would have been entirely appropriate to give her the albuterol. No one's saying that he was negligent by giving her the albuterol. No one's saying he was negligent by ordering the EKG. What he needed to do was order one more test, a troponin. And given her risk factors and the risk stratification of her being a smoker, a diabetic, with hypertension, that's going to increase the potential risk that she's dealing with a cardiovascular cause. And because of that risk stratification is going up, and she's going to be at least a moderate risk if you're looking at a heart score or a high risk on other thresholds, and you're going to want to hold this patient for observation with serial troponins. So not only did Dr. Love need to do a single troponin, he needed to do additional troponins to continue working up this patient's cardiac causes. And had that been done, her MI would have been caught. She likely would have been sent to the cath lab, and she likely would have been fine. And instead, Stacy, you heard a little bit from the judge at the outset of this case, she has 2 children. And now those 2 children have to grow up without their mother because of Dr. Love's decision not to order a troponin. I've had the privilege of representing Stacy and her family up to this point. I now pass that responsibility on to you, ladies and gentlemen of the jury, to find the only just result in this case in favor of Stacy and her family, and to make sure that incidents like this do not happen to any other patients, so no other family has to go through what Stacy and her family have had to go through. Thank you.
The defense.
Thank you, Your Honor. Ladies and gentlemen of the jury, as a reminder, the burden of proof is on the plaintiff in this case to prove that Dr. Love was not reasonable by a preponderance of the evidence. So what you will hear and what that means is that if you're balanced, if the evidence is balanced, or even slightly tips you towards Dr. Love, plaintiff has not met their burden of proof. Now, the records in this case described by the patient state that her chest pain is worsened by deep breaths. That is pleuritic chest pain. You heard that that is not a classic symptom of acute coronary syndrome. There are also many negative findings in the patient's history and on physical exam that would lead Dr. Love away from a cardiac origin of the patient's presentation. And the plaintiffs want to talk about risk factors, and you heard from Dr. Kaide, plaintiff's own expert, that risk factors don't diagnose patients. You have to look at the whole presentation, the symptoms, and the test findings, the EKGs, the 2 EKGs that were normal, no ischemic injury. All of this led Dr. Love to conclude that bronchospasm was a reasonable diagnosis for this patient, and you heard that decision-making supported by Dr. Wipprecht, a board-certified emergency medicine physician. So, ladies and gentlemen, as you deliberate, there's one question that you need to answer in this case. Was Dr. Love reasonable in his care and treatment of Stacy? And that answer is yes. And that is the only question that you have to answer in this case. And we ask that you return a verdict in favor of Dr. Love. Thank you very much.
So this concludes our trial, And next is the jury. So we're going to have our jury deliberate, and I'd ask all of you to think about this beforehand. So here we're actually, the instructions to the jury. Good morning, ladies and gentlemen. This is very, very brief. Welcome back. The evidence portion of the trial is concluded. Determining whether an issue has been proven by preponderance of the evidence, you should consider all the evidence regardless of who produced it. If the weight of the evidence is equally balanced, or if you are unable to determine which side an issue has the preponderance of the evidence, the party who has the burden of proof, i.e. the plaintiff, has not established such an issue. Specifically, the plaintiff alleges that Dr. Love, the treating emergency medicine specialist, was negligent in failing to work up the patient for potential cardiac problem. The issues for you, the jury, to decide are the following. Number one, this is standard of care. Number one, has the plaintiff proven that the defendant was negligent in one or more of the claims against him? And number two, if your answer to the first question is yes, was such negligence a proximate cause of the injuries and damage sustained, including death of the decedent? So let's give the jury about 4 or 5 minutes to deliberate, and one minute to deliberate. But while they're doing that, I'd ask everyone else, we'll show of hands after they come up with their verdict. And if you guys have a jury foreman, or four-person that can do that. But while you're thinking of that, yeah. We'll time this also. All right, we'll give you another 30 seconds. All right, jury, have you reached a verdict? Please vote. No. Please vote on your verdict. While they're having their final deliberations, I'm just going to have all of us, with show of hands, 2 questions. First of all, if you were the defendant, who would settle this case? Who would go to trial? Who is really glad they didn't see a 41-year-old who had, like, wheezing on lung exam? Right, exactly. I get it. All right. Okay. So, jury, have you reached your verdict? Okay.
We reached a majority, but not a
Okay. Interesting. Okay. Why don't you stand up and here? Do we have one of the mics? We can. I don't know. Just hold it real close to your mouth. What has the jury decided?
So the majority of the jury decided that he is not guilty.
Okay. All right. And because that was the decision, we do not need to vote on the second half, which was the causation. Can I have everybody one more time? If you had to commit, who would say they're going for the defendant in this case? And who would defendant him? Yes. And who would go for the plaintiff in the case? Most people. So that's what we find a lot of times, that we are more harsh on ourselves than an actual jury would be, which is maybe 85 or 90% for the defense. So I know we're sort of at the end of time. I just want to do a couple things very, very quickly, and then we can stick around for a few minutes to anyone who wants to stay. Dr. Love, how did you feel going through this process? Not great. Not great. And what would, if there was 1 or 2 lines that you could put in your documentation while that patient was still there in the ED with you, what would those lines have been?
Definitely explain more about any kind of exertional component and try and support the fact that this wasn't the only thing.
Great. So better data gathering with the exertional part, et cetera, and then also in the MDM why you didn't think it was exertional pain. Mr. Hoover, what was your thought? What would you have wanted to see in the documentation that would have made your side easier? Yeah. Would you have taken this case for the defense, or would you have settled this case?
Probably try to get early resolution. Yeah.
Okay. All right. And that was really the biggest thing that he could have done to help him defend this case as far as the documentation. If you had seen it. Oh, order the Tribunal. Okay.
I think a lot of it comes from my conversation with Dr. Kaide. One of the things plaintiffs don't have the benefit. One of the things plaintiffs attorneys don't have the benefit of is we don't have doctors that we can quickly just consult with about these cases without having to pay them extraordinary rates for their hourly time. So it was invaluable to have him as a resource, but knowing that truly is just kind of the standard to do serial EKGs and serial troponin testing to make sure there's no cardiac cause, that's what seemingly needed to be done, at least based on what I understand.
So I'm going to tell you just brief in the last maybe 60 or 90 seconds, and everyone can go. We'll stick around. I'm volunteering you guys to stick around, but you can go if you want to also, of course. So what happened is Stacy got sent home. Her daughter was woken up about 3 o'clock in the morning with some rustling around in the kitchen. She walked out back. It was a warm Texas night and found her mother sitting on the back steps smoking a cigarette. And her mother said something curious to her. She said, you know, if I've ever not treated you or your brother in a way that you should be treated, or if I've ever been unkind, I apologize for that. Which her daughter thought was sort of curious. It was 3 a.m. They're both sort of tired. And the next thing her daughter knows is that the mother collapsed, the patient, Stacy, collapsed, and she was doing then chest compressions on her mother while calling 911. Autopsy the next day did reveal that this was an MI that she died from. So that was actually a firm diagnosis. The physician defendant was on the stand, but unbeknownst to the jury, that physician had already settled that case. And in the middle of the trial, unbeknownst to their own defense attorney that they were going to say this, they came up with this whole line about how the defendant physician's own mother had gone to their primary care doctor with chest pain several years previous, and had been told that they were a nervous housewife who drank too much red wine. And the defendant's mother had actually died of a heart attack. And then this defendant is treating a little bit different, but a similar-ish type of situation. And again, the Weinstock World Medical Malpractice, poor data gathering, poor medical decision-making, as reflected on your documentation, didn't really occur. So the really exciting thing is we have books for everybody here. I think there's enough for everybody here. Might be very close. And the last case in this of the medical legal book is this case. So if you want to read the actual trial testimony that happened, this was a Texas case. I said that the physician settled, and then what happened is I believe the hospital, well, I'll let you just read, but I think they went for the defense, but it is Texas, and basically they have this willful and wanton standard that basically you need to stab a patient with a knife before you will lose as a defendant or something. So anyways, we have these books for everybody. I have a couple of these of the critical care book, and then I did bring this one that Colin referred to a bunch, this risk management with a lot of OSU authors in this, as well as other national authors, that I'll let you decide who gets this one. So anyway, thank you everyone so much for coming and sharing your time. Thanks to this guy, big thanks, and everyone for just devoting their time to us.
Oh, you did too, man.
Yeah.
I'm going to get troponins on every patient.
Right, exactly.
Every patient we're going to see now.
Thank you, guys. Very
Oh
nice.
my gosh,
Appreciate
Zach,
it.
thank you so much. I know you got to take
Yeah,
off,
I
but
gotta run,
you
but-
got your book. I mean, thank you. I mean, taking this time and devoting it to this is so good. But I mean, these guys just ate it up, So really great. All right, sorry it went over, but thanks again.
it's
man.
okay.
All right, good. All right, we'll be in touch with all other stuff. Yeah, so I take these.